again so much for inviting me, and to Barrett for facilitating this talk. And as I said, I'll try to keep it as engaging as possible. And of course, please stop me at any moment. My name's Alex Rabin, and for those of you who don't know me, my slide, of course, froze. Okay, there we go. For those of you who might not know me yet, you're probably like, who the heck is this guy? I thought I would just do 2-second introduction. So if you couldn't tell already, I grew up in the Boston area in a little town called Wayland, about 45 minutes west of Boston. And I'm very proud of my proud of my upbringing there. And so my background, actually, I was a musician, and I started when I was 6 years old playing the piano, as Jane well knows. And I got to college and I met this guy, Boris Berman, who was a very intimidating Russian professor of piano, who basically made me realize I was not quite cut out for a career in music. So I'm proud of it. I'm thankful to him for that. But at Yale, I was very lucky that I actually got to meet my wife, and we went on a cross-country bike trip together right after we graduated. And that was the beginning of our relationship, and we've been together ever since. And after college, I went to Emory Medical School. Again, very proud of my time there. It was probably the highlight of my education. And as some of our fellows know, just a really, really great place to learn medicine in an urban environment. And after Emory Med School, I went back to Boston, actually, and did my residency and fellowship, bounced around pretty much all the different hospitals in Boston. And it was there that I actually got to meet Mary Rice, who some of you may know through ATS, and she's just a force of nature, really. And she is an expert in environmental lung disease, and really a climate warrior, and we worked together actually closely on some advocacy efforts, including passing a greenhouse gas reduction bill in the Massachusetts State House. And I take very little credit for that, but something that we worked pretty hard on to get that through, and that passed a couple of years ago now. So Mary has just been a phenomenal resource and mentor to me. And it was also while I was at BI that I happened to meet this guy, Jake, who was my associate program director. And it's really thanks to Jake and then Jane and then John and others that I was able to find a position and a home here in Ann Arbor. And so I'm really thrilled to be here. We came here in September, and I've been here ever since. And I just want to show 2 pictures of my kids. That's Simon in his ballet attire, and Izzy, who just turned 2 yesterday. So that's a little bit about me, and we can keep going now. So how did I even come about getting an interest in climate and environmentalism? You would think, it's a little ways away from what we do on a daily basis. And it's funny, actually, my first experience really and first recognition of what was going on with our climate and global warming was really when I did a project in 8th grade. And does anyone know where this is?
Venice.
Yeah, exactly. So this is the Palazzo Ducale, right, in Venice, and this is St. Mark's Cathedral and behind it. And I did a project actually at the time. I did a project on what was being planned, this mega engineering project called the Moses Project, which was this sort of incredible engineering feat to build something like 79 300-ton gates to protect the city of Venice from the increasing amount of flooding that was happening in what are called these acqua alta, where the lagoon, basically the tides rise and flood the city. And when I was doing this project, and then I was able to visit Venice and years later, it just it was a very, I don't know, it just somehow it struck a nerve that this peak of civilization, this just incredible beauty was so threatened, and a lot of this was due to pollution, climate pollution that we were doing to the world. And basically, maybe I thought maybe there's an opportunity to make a difference in some very small way. And so I think that was sort of where I got interested in environmentalism. I'm not really like a tree hugger or anything like that. It really came about from this very formative experience and learning about Venice and going there. And so anyway, I just wanted to share that where that came from. So that's too much about me. The objectives of this talk, hopefully it will go from least controversial to slightly more controversial areas. First, I just wanted to make sure everyone's on the same page and is up to date with the most recent trends in global warming and where we are and what's going on, so that we have a basis to talk about some of the respiratory health effects of climate change. I'll talk briefly about where the current recommendations are as far as counseling patients on what to do in preparation for climate-related disruption and health impacts. And some of that actually comes from very recent literature, including, if you guys saw just this week, last week, the New England Journal of Medicine has now announced a year-long initiative to release literature dedicated to climate and health and fossil fuel pollution. So that's pretty cool, and I encourage you to check it out. And then we'll talk about some of the dirty truths behind healthcare delivery and greenhouse gas emissions, and then I'll talk about kind of my latest pet project, which has been looking at some of the emissions related to the inhalers that we use every day. And hopefully that will be some new information for you guys. So stepping back again, this is probably not news to anyone on this conference call, but we are facing a very serious problem. And this is the Keeling curve, so-called Keeling curve, which is the CO2 concentration dating back 800,000 years. And as you can see, there have been fluctuations over this very long time period, and this is as measured by ice cores. And then there are direct measurements since about the 1960s 1958, from Mauna Loa in Hawaii, where they directly measure atmospheric CO2 levels. And as you can see, our CO2 levels currently in the atmosphere are, as of this morning, 421 parts per million. And when I first did my project on Venice, and I think I was in 8th grade, the average CO2 concentration in the atmosphere was 360. So the problem is accelerating, and we have yet to make any kind of dent as far as CO2 emissions. And this is very tangible. And I think today was a very apt day to discuss it when we have a high of 96 degrees here in Ann Arbor. And we see the warming trends affecting really everywhere in the world, but northern latitudes are even more affected, and the effects are more dramatic. And here you can see in Michigan's annual average temperature trend from 1895 to 2019. We've warmed over a degree Fahrenheit, I think a degree and a half Fahrenheit so far. Not only that, the number of 90-degree days like today is going up from the single digits from the historical average to something like by 2050, it's projected if we continue on the same emissions trajectory, we're going to be having over a month or so of 90-degree days in the summer. So this is really very, very concerning. So what are some of the health effects of a warming Earth? Well, Again, most of these probably are familiar to you guys. Heat waves are probably the best measurement, most palpable, most direct connection to climate change and global warming, but also heat-related smog events. And as you may be familiar, smog, which is photochemical smog, which is produced from the chemical reaction of nitric oxide compounds, volatile organic compounds, and other things in the air pollutants, when exposed to heat and light, particularly during the summer months, produce secondary pollutants. And the main one of those secondary pollutants is tropospheric ozone, or ground level ozone. So those smog events are getting worse as we have more heat. And so the combination of combustion products and heat create more smog events. The ones that I will focus on today will be increased pollen and also forest fires, and what effects those have on our respiratory patients. Clearly, as sea levels rise, we're going to be seeing more flooding. This is probably the best example is of Hurricane Katrina, when many homes flooded around New Orleans, and as a result, there was extensive mold damage and mold injury, and there's documentation of increased respiratory sequelae of all that mold. And then the last one, which we probably think a little bit less about, but we do need to be thinking about, particularly with vulnerable healthcare infrastructure, such as Tampa General Hospital, the hospitals around Boston, the hospitals in New York, like NYU, that flooded. As we see more and more extreme weather, healthcare infrastructure is definitely going to be affected. And there are also secondary effects, and one of the ones that I personally experienced, and maybe many of you as well, was during the supply chain disruptions that happened after the hurricanes that hit Puerto Rico, when we lost access to small IV bags and therefore had to switch our medication delivery to syringes. And so that was a definitely very palpable secondary effect of severe weather. So we're going to focus briefly here on pollen and forest fires. So pollen, the amount of pollen in the air and the extent of pollen and other tree allergens is going up as the climate warms. Interestingly, there is a direct link to atmospheric CO2. And in fact, in this paper published now a couple of decades ago, the scientists took flowering plants in a greenhouse and exposed them to different concentrations of ambient CO2, and noticed that plants basically are much more productive at producing pollen at higher CO2 levels. And not only that, not only that, but pollen season is expected to be. Is this bar in the way? Sorry, I can't see.
I don't see anything in the way.
Oh, okay, great. Sorry, maybe that's just from me. Sorry. So pollen season is expected to be longer in the U.S. and these are modeling. This is a modeling paper, but essentially you can see that curve is getting wider and wider, and essentially this is logical, but as our spring starts sooner and the fall goes longer, as the climate warms, plants are basically more productive at producing pollen for a longer period of time. And this paper is actually taking direct measurements from monitoring stations around the United States, and the size of the circle corresponds to the number of years that they have data. So 25 years is the biggest circle, and what you can see is that for the most part, the stations are detecting more pollen as they become darker red. That indicates a higher amounts of pollen, and the parts of the country that are seeing the biggest increases in pollen also correspond to those areas that are warming the most, and those are basically the Midwest and the northern part of the United States. So we are in the crosshairs here in Michigan as far as a longer, more intense pollen season. And obviously, I don't need to tell you guys all that more pollen, more allergens mean worsening asthma, more exacerbations, more allergic rhinitis. And there's lots of evidence suggesting that is the case. So when patients say that, yeah, my allergies seem to be getting worse, it's backed up by the evidence. The other major effect that, of course, we're seeing as pulmonary physicians and will be seeing more and more are wildland fires. And really, wildfires are exploding across the world. And I think actually this figure that was put out by the Lancet last year, I don't think even really does it justice, because in the United States, again, depending where you look, it's sort of averaged out. The number of wildfire days is just exploding. And that's driven by a lot of factors, in part from related to forest management and the lack of prescribed burns for years, but in large part and probably predominantly driven by severe drought. And of course, the West is in a mega drought right now, as well as increased temperatures. And this is true not just in the Western United States or Canada, but it's true in Siberia, where they're seeing absolutely unprecedented fires. And of course, we had the catastrophic bushfires in Australia that happened a year or two ago now. So wildfires are exploding. And this is a just graphic from a couple of years ago. And again, it doesn't include even the most dramatic fires that happened, I think it was 2020 in California. In this paper from Mary Rice, showing wildfire acreage and acres burned. And so that trend is going up. So health effects of wildfires. The effects of wildfires are severe, particularly for those closest to the fires. And it's believed that actually there is substantial evidence that wildfire smoke is worse than your average particulate matter, as everything gets burned. There's incredible amounts of black carbon that are produced and other pollutants. And just to save time, I didn't present all of the data here, but there's now been countless studies showing that folks who are in the path of wildfire smoke go to the ER more. There are more childhood asthma exacerbations, emergency visits, and there is a trend to increasing all-cause mortality among those who are exposed to the most severe amounts of pollution from wildfire smoke. And it goes without saying that those who have pre-existing respiratory disease are the most vulnerable. And one thing to remember, of course, is that wildfire smoke can originate in one place, but it doesn't have to stay there. And in fact, as this was my first slide of the presentation, this is actually Boston. And I believe, sorry, I forgot to write down the exact date, but I believe this was in 2020 when we were feeling the effect of smoke that had blown across from Canadian wildfires. And the air quality was the worst it had been ever recorded in Boston for the last decades. And I believe a similar thing happened in Michigan as that same smoke cloud blew across the continental United States. So this is not a joke. Like this, these events are going to be happening more and more, and we need to be prepared for them as physicians taking care of patients who are especially vulnerable. So how can we try to counsel patients? How can we try to adapt and prevent patients from having bad outcomes? Well, I think the best resource and the most recommended is to go tell your patients to go to airnow.gov. And I know a lot of weather sites now have this available, including on your Apple app, weather app. But I think this is really helpful. And so what is the air quality index, AQI? It's basically a composite index that is put out that combines the major air pollutants, including particulate matter, ground level ozone, and other pollutants, that basically gives the general public a sense of how safe it is to be outside during a particular day. And although most of the time our air quality here in Michigan is in the good or moderate range, actually, as Jane was pointing out, the air quality in Ann Arbor is actually worse than it is in the East Coast. There are days when our air is unhealthy, particularly when there's wildfires or even just from other fossil fuel pollution. So it's something to look out for. And I measured it. I took a snap from yesterday. In fact, again, just today, our air quality is on the border of orange. So it's really not good. And combined with the extreme heat, today would be a good day to counsel your patients to stay indoors if possible. So what else can we tell people? So trying to reduce exposures, staying indoors during poor air quality events, closing windows, running air conditioning. If they don't have air conditioning, then trying to make sure that they have a plan to stay with family or going to a cooling center, a senior center, something like that. That can really save lives. Now we don't really need to coach people on respirators because everybody knows what N95s are, whereas they didn't probably 2 or 3 years ago, but respirators do really work to reduce particulate matter, particularly during wildfire events. There is increasing evidence, although it's still, there are ongoing studies, including one that is being run in Boston that I know of HEPA filters. But there is increasing evidence that among patients with COPD in particular, that use of a HEPA filter, particularly when the windows are closed and they're running it appropriately. There was a recent study published in the Blue Journal last year that suggested that running that air purifier did seem to reduce symptom burden among patients with COPD as compared with a sham air purifier. So I think there will be more and more evidence coming out about this. I sometimes hesitate about recommending that everybody go out and buy a really expensive air filter, but for your most vulnerable patients, and obviously for those who live in wildfire prone areas, it's probably a good idea. And then there's increasing concern about cooking, and particularly natural gas stoves that produce high levels of pollutants in an enclosed space. So having good ventilation is a good idea, and ideally switching to alternative forms of cooking. Probably have bad health effects on patients with lung disease. And then it goes without saying that we want to try to treat comorbidities to minimize risk. So encouraging folks to use active forms of transportation, riding public transit if possible, walking, biking, eating healthy. And then, of course, good preventive care, making sure that they're on their right controller medications if necessary, reducing allergen exposures. All of those good medicine are these evidence-based recommendations that are out there now. And again, this is, I just wanted to put a plug in, this is from the new series that the New England Journal has just inaugurated as of last week across all of their platforms, looking at the health and impacts of climate and air pollution on patients. So in order to bend this curve, which is in panel A, as you can see, which is very disturbing and scary, this needs to be a global effort, and we need to transform how we move around. Transitioning away from big polluting SUVs to electric vehicles, among other things, changing how we generate power, getting away from coal and moving towards cleaner forms of power production and renewables, changing the way that we heat our homes. It's really a economy-wide change. But as physicians or as healthcare providers, we actually have an outsized role to play here, in my view. First of all, healthcare contributes 8.5% to 10% of total US greenhouse gas emissions. And I think that's just a reflection of how important the healthcare industry is in the United States, what a huge part what a huge part of our economy it is. But our healthcare, the healthcare that we deliver, is a massive contributor to global emissions. And I'll get into that in 2 seconds. I'll show you some data on that. And moreover, in my view, again, I think that as healthcare providers, our goal should be to promote health and well-being for the public. So addressing this issue is not just like a side thing. I think that is really at the core of our mission, because if we continue on the path that we're going right now, it is very clear that the health of our patients will suffer. So right now, we are not in a good place, as I mentioned, and US healthcare emissions are the highest per capita of any country in the world. That probably doesn't come as a huge surprise, but we have an outsized impact on greenhouse gas emissions. And just to quickly review, because this comes up a lot in the lay press too, just so everybody knows. So when we talk about emissions of health of industry, like car industry or the healthcare industry, they talk about scope 1, 2, and 3 emissions. And so what that means is, so scope 1 are the direct emissions produced by healthcare facilities. Scope 2 are the emissions that are released by generally purchasing electricity to run the facilities. And then scope 3 are all the other emissions related to the supply chain and all the stuff, the equipment that we use in the hospital. So as you can see, the direct emissions are actually a relatively small percentage of the total emissions, and reducing the supply chain emissions is the hardest part. Just as, for example, for GM or something, to reduce their emissions from the production of the cars is actually relatively easy compared to actually reducing the emissions, zeroing out emissions of all of their products, the cars and trucks that they produce. So the same is true for healthcare. And as you can see in this study from Health Affairs, from 2010 to 2018, actually emissions only went up, and they went up about 6%. So that's pretty discouraging. On the other hand, the United Kingdom, which actually does the best job of any developed country, to my knowledge, they mandate tracking of healthcare emissions. They have actually seen a reduction, as you can see, from 1990 to 2019 in the emissions produced by their National Health Service in England. And because they are mandated to keep track of it, actually, they also do a really good job of breaking down exactly studying what part of their healthcare emissions can be modified to try to reduce the impact of the care that they provide. And as I was kind of looking at this and talking with friends who are interested in this work, one of the ones that, as I was looking at this, one of the sections that came out, or one of the contributors, was MDIs, meter dose inhalers. And as probably many of you have heard of, anesthetic gases, that we know that those are potent greenhouse gases. Nitric oxide is a very potent greenhouse gas, as is desflurane, which is an anesthetic gas that's used less and less because of climate concerns. But I actually hadn't heard anything about meter dose inhalers, and I'm curious if some of you guys had come across that either. I know some of the fellows know because I've talked to them about it, but this was something that the Brits were really focused on, and I said, well, gosh, I haven't even heard of this, and I prescribe these inhalers all the time. So I wanted to quickly review how inhalers work. And again, this was new to me as I learned about this, and maybe you guys will learn something too. So inhalers come globally, they come in 3 basically different delivery mechanisms. The first is a meter dose inhaler, and this makes up about 90% of inhaler sales in the United States. And in Europe, it makes up a smaller percentage. In some countries like Sweden, for example, they only use 10% meter dose inhalers, so very different from the United States. But as I said, this in the US, the most common form is a meter dose inhaler. The components are pretty simple. It has a canister that contains an aerosol propellant with a drug suspended in it. And when you push the canister button on top, there's a valve that opens and patient gets a puff of this pressurized aerosol gas, and it goes into their lungs, and that's how they get their medication. On the other hand, dry powder inhalers, which basically come in lots of different shapes and sizes and flavors, work on the principle that essentially you have a dry powder form of a medication that is released by some kind of mechanism, whether it's a blister strip, as in the discus, like Advair discus, or a powder reservoir, as in the Turbuhaler, which I'll talk about in a second, which is a form of Symbicort that's available, but not in the US. And basically, or the other one, the good example I think of is the Spiriva HandiHaler. So you put in a little capsule, you crush it, it has a powder in it, you release the powder, and you inhale it, and it can either be released passively or actively. And most of the time, it requires an active inhalation to get that medication into your lungs. But they work great, and a lot of patients use these. And then the last one is called a soft mist inhaler. And actually, to my knowledge, there is only one type of soft mist inhaler, and that's the Respimat, and it's a proprietary inhaler that's made by Boehringer Ingelheim. And this one, again, if you work at the VA, I know you'll be familiar with this one, but basically it has a spring that somehow magically, you twist it, it releases the spring, and then basically it creates a mist that contains the medication, and the patient then inhales the mist. So of these three types of medication delivery devices, the meter dose inhaler is the only one that uses a aerosol. And the aerosols that are used currently are called hydrofluorocarbons. And hydrofluorocarbons are compounds that are used very widely in lots of industries, including primarily in refrigeration, air conditioning, in foam, in fire suppressing foam and fire extinguishers. About 5% of them are used in aerosols. And actually, these are very potent greenhouse gases. Now, you guys may remember, those of you who've been practicing for a little bit longer may remember that back in the day, meter dose inhalers, pressurized meter dose inhalers, were loaded with CFC propellants, chlorofluorocarbons. And these were, they worked great, but the problem was that these chlorofluorocarbons were very potent at depleting the ozone layer, as well as potent greenhouse gases. And so this monumental global environmental treaty was passed, called the Montreal Protocol, in 1987, that led to the phase out of CFCs. First of all, in all like air conditioning units and other aerosol uses, and eventually it made its way to inhalers. And because there was a phase down globally of production, prices went up for CFCs, and eventually the pharmaceutical industry adjusted and came up with an alternative, which was the HFC, the hydrofluorocarbon, also known as HFA. It's a little bit confusing. So anytime you see something that says HFA, that's hydrofluoroalkane, it is basically synonymous with HFC. And so these were replaced in the 1990s. And the unfortunate thing that happened as these inhalers were replaced was that the pharmaceutical industry used this as an opportunity to put common inhalers like albuterol all back on patent, and prices skyrocketed. So that was the unfortunate reality. But what was also unfortunate was that they replaced the one bad gas that was killing the ozone layer and replaced it with a gas that's still very bad for the climate and a very, very potent greenhouse gas. And one statistic that may make you think twice about it, using HFAs all the time, is that one puff of an albuterol inhaler is the same as driving 1 mile in a car. And in the US, where we prescribe 144 million HFA inhalers every year, that's about the equivalent of driving 500,000 cars on the road for a year. So it's not the biggest contributor to climate change, but it is a substantial contributor in my view. And so now companies, particularly in Europe, where they have now said that they are going to phase down HFAs because of climate concerns, they are coming out with newer versions of these hydrofluorocarbons, including HFC 152A and HFO 1234ZE. And these are already in development and are probably going to be coming out in the next couple of years. The good thing about these ones is they have really an order of magnitude less global warming potential when it comes to HFA 152A, and almost no global warming potential when you're talking about the bottom. Now, Symbicort. So the reason I bring this up is that Symbicort, for those of you who prescribe a lot of inhalers, Symbicort is like the SUV of inhalers. So for one thing, it's one of the few inhalers that actually uses HFA 227 or HFC 227A. And this has the global warming potential that's 3 times that of the most other inhaler device. Why they use this particular propellant it's not clear to me. I think that it was just that's how it was developed. And the other thing is that it has the highest volume of this propellant. So Symbicort has a ton of this nasty aerosol, unfortunately. Now, and again, the reason I bring up Symbicort is that Symbicort right now, that and Dulera are basically the only drugs that we have available to us to implement smart therapy, or if you're from Boston, smart therapy. And so basically, what may or may not be known to you is the irony of this is that smart therapy was studied globally. 15 of 16 trials, to my knowledge, that I looked at, were all conducted in a dry powder form. And so actually in the United States, we actually do not have an FDA label approval for smart therapy. And so when we use smart therapy, it's always off-label use. So in my view, this is a really big opportunity, potentially, to try and lobby the drug manufacturers to hopefully get us some drugs that we can use for smart therapy that might not have as big a climate impact and would probably be better for our patients, because then we can actually have a drug that's paid for by insurance. Because if it's not covered, if the FDA doesn't have approval, doesn't give approval, it creates a lot of pain and headaches. So this has been kind of my little pet peeve lately, is trying to understand this and trying to advocate for cleaner inhalers. And pretty much all the studies and all of this information comes from the United Kingdom and Europe, because here in the United States, this is really basically it's been an invisible issue. There have been a couple little things published in the late press about it, but really it's essentially an invisible issue. And in Europe, they've actually measured this and looked at this. So what happens with patients, for example, who use a lot of inhalers? Well, not surprisingly, those who have poorly controlled asthma also have much higher carbon footprints, release a lot more CO2 equivalents from their inhalers, and mostly that comes from salbutamol or albuterol, excessive use of rescue inhalers. So it's really an opportunity to not only get these people to not using as many MDIs, but also controlling their respiratory disease. And there have been a couple studies that have now looked at what happens when you try to switch people from MDIs to DPIs, from pressurized meter dose inhalers to dry powder inhalers. And this is a paper that was published just this year. It was a post hoc analysis of uh, what was called the Salford Lung Study, which is a study of asthma and COPD run in Salford, United Kingdom. And what they did basically was they randomized patients in an open label way. This was sort of a real world type of study where they randomized patients to switch to a combination LABA ICS with a DPI from their prior therapy of primarily MDI-based treatment. And so they randomized to that versus control, which was basically patients continued to use whatever they were using previously. And what they showed was by getting people to actually switch, they dramatically reduced CO2 emissions. That was primarily driven by switching people to a dry powder inhaler, which has substantially less carbon emissions, somewhere on the order of 20 to 200 times less carbon emissions. But interestingly, in this third column, you can see they actually got them to, they had better control when they were on a DPI LABA ICS. And as a result, they used less rescue inhaler, which also contributed to less carbon equivalent emissions. And the most important takeaway for me was that actually asthma control, as measured by the asthma control test, did not change. So over time, so despite the fact that they switched them, there really was no impact on asthma control. So I think that there is now plenty of anecdotal and now real world evidence that would suggest that for a lot of patients, we can be using dry powder inhalers with equal efficacy while still reducing emissions. And the European Commission has already proposed a quota system to try to restrict future supply of HFCs. So the Europeans are leading on this. So it's just a matter of time before the United States, I think, catches up to this. And I think we have an opportunity now to be proactive and do it in a way that's not going to hit people with really high-priced inhalers in the future, as happened during the CFC to HFC transition, which was really, really tough for a lot of patients. So basically, Emily, our fellow, and I, Emily was wonderful. We worked on this together. We put out a piece that's coming out next month in the Annals of ATS, describing this issue and calling attention to it in the United States, and hopefully getting folks to at least think about it. Again, we're not saying that dry powder inhalers are for everyone. Absolutely not. There are patients who are kids or older patients with severe obstructive lung disease for whom they have to use an MDI, and that's totally fine. But there's also a lot of patients in the middle who really, when I was prescribing, often I would just be clicking, honestly, randomly on whatever inhaler comes up first, whatever LABA ICS comes up first on the formulary. Well, maybe we should be a little bit more thoughtful about it. And if we have an opportunity to reduce harm, hey, let's take it. Because as I mentioned earlier, we have an outsized impact as healthcare providers on the climate, both through how we're emitting, our healthcare facilities are emitting, how our supply chain is emitting, but also we can set a good example. And if we can talk about this with patients and get them to recognize the issues, I think there's something good to be done there. So that's my view. So takeaway points today. Basically, hopefully I've convinced you that the respiratory health of our vulnerable patients is at risk in the changing and rapidly changing climate that we're experiencing on this 96-degree day in Ann Arbor. Think about the weather. Think about counseling your patients about air quality events and how to prepare for them. Remember that everything we do in the hospital and the outpatient clinic has some impact on the climate, and so maybe there's this opportunity that we can actually make an impact directly by slightly modifying our prescription habits and eventually advocating for reduced emissions from healthcare. So that's all I got today, and I would love to talk and hopefully stimulate some conversation here.